On behalf of Intas Pharmaceutical Limited and Janet Division, I, Dr. Mithilesh Nayak, welcomes you all to this first episode of Meet the Professor Cardiology Masterclass, a specially designed program for DM cardiology students. This unique program aims to enhance students' clinical skill, diagnostic acumen, and overall preparedness for both practical as well as theory examination. This program is structured across multiple focus sessions. The course will cover key practical aspects for the examination. And to guide us today, we are having with us our course director for the program, Dr. Ramakrishnan. He is currently a professor in Department of Cardiology at prestigious AIMS, New Delhi. He is actively involved in clinical research, patient care, and educational activity. He has performed a few innovative interventions and he is among the first to use alcohol ablation for RVOT obstruction. Dr. Ramakrishnan has authored around 210 publications in index journals and his papers have been cited more than 8,000 times. He is also a PI and co-PI in many national and international trials. He has won numerous awards including DP Basu Award, Nanda Award, Sujay B. Roy Award, Best Poster Award in ACC, AEPC, and APPCS. He is also won Young Investigator Award in PCSI and Colonel Chopra Award. Besides this, he is very active in academic and he guides a DM student uh, at AIMS New Delhi. Uh, Dr. Ramakrishnan will provide us complete guidance for the throughout the session as well as in future session as well. Uh, so in today's session, he's going to guide us on a unique aspect that is the simplified approach to the long case. So how you can approach your examination when you are assigned to long case. That is what the today's session. With this word, I hand over the session to Dr. Ramakrishnan. Over to you, sir.
Thank you, Dr. Mithilesh. Can somebody stop sharing? Yeah, thank you. So I think there are multiple forums, and sometimes the forums are doing for discussion like this. We thought I think there's a good forum where we can actually take the level of academics to a different level, where we cover in a systematic fashion over 3 years monthly classes, where we cover the core curriculum of cardiology, as told, like mostly focusing on the clinical examination, but to some extent focusing on the theory exams, which are very important, which are Indian-oriented data that are not commonly available in a textbook. That will be our endeavor. So we'll try to cover the whole aspect of cardiology in 3 years. And some of them will remain the core principles, some of them will be the recent advances, and all those things will be covered. So we have already created a list of, say, 100 topics that will be covered with the various top opinion leaders and KOLs will be lecturing it. And they all will be available for everybody to see in various forums. So I think that will be a very useful addition to whatever addition that you have, and mostly it all will be taken by most of the seasoned examiners who are part of the many exams. So one is preparing for exams, and the other one is preparing for your life. And we'll try to cover balance both, where I think knowledge is not only helpful for your exam, but also for your day-to-day patient care and improving your skill sets and improving knowledge of cardiology. So coming to today's topic, I just was thinking about doing this. I teach this way in for my undergraduate graduates for now many years now. I think that is really caught up the attention of the PGs also. So I thought, why not use it the same approach to teach the DM students also? Because ultimately the case remains the same. So the case, for example, a rheumatic MS AR is going to remain the same in MBBS, MD, and DM level. Only the complexity increases in DM level, and your understanding of natural history and your understanding of hemodynamics change in DM level. That's what we expect. So the approach to a case remains constant. Let us try to oversimplify a cardiology long case. How easily it can be approached. So long case in examination has always been a examiner's delight. So examiner comes fresh in the morning, starts by taking the thing, and then it goes on for quite some time. It goes on for like say maybe an hour and a half, at times maybe an hour. Then, but unfortunately, as much the examiner enjoys it, the examinees don't enjoy it. Like so, it's always examinees treated like a nightmare. What is the long case is all about? Long case is all about a primary test of synthesis. Like so, for example, as a cardiologist or as a physician, we go through a lot of areas which are gray, which are not black and white. So this is black, this is white. That's not there in most of clinical cardiology as well as in your practice also. Like for example, addition is borderline. So whether to vascularize or not. So you tend to bring in your experience. Same thing is needed in clinical cardiology also. You're just putting which one to put first, which is more important, which is less important. So how do you synthesize your case? Which one you give importance, which one you don't give importance, history, in examination. That is what it goes like. It's very simple. Actually, if you have a good approach, it's actually pretty simple. So what is the problem like? Problem is that oftentimes we don't take charge of the situations. We never accept the challenge. We want to run away. We just want to finish the exams and run away. And remember that exam is not a fight for life. Earlier era when failures was so common, some of the top intervention cardiologists or some of the topmost cardiologists have already failed in their exams. Like so, it's not a big deal. Failing or passing in an exam doesn't mean anything in your life. Like remember that. So I often tell jokingly, only two people have to be worried about the results. Like one who have in-laws who are not medicos, who don't understand how difficult or how easy is it to pass a DM cardiology exam. Number one. Number two, you have a slightly grown-up child who can understand what it means to fail an exam. So the child should not come and say, "Oh, Papa, you have failed," or "Mummy, you have failed." So that kind of a thing should not happen. Like those are the two people who have to worry about passing and failing. Otherwise, passing and failing hardly matters. The moment you come to this mindset, actually, the exams are will put you a lot of less stress on you than other things. And actually, in cardiology, only a limited number of long cases can be given to you. So only a limited number. Think about anybody can think of anything more than this. Rheumatic heart disease or some form of valvular heart disease. Nowadays, people may keep you degenerative AS and MR, or sometimes bicuspid is also given. Rarely MBPS is also given. So then you have cyanotic angle heart disease. Some other institute may keep it as a long case, but generally it's reserved for a short case. Definitely, if you find a Lutembacher with a lot of findings are there, generally it's kept as a long case. Sometimes RSOV and VSD are also kept as a long case. Actually, practically for all practical purposes, 90% of the time you are likely to get a rheumatic valvular heart disease as a long case. So only these are your short cases. Like what are the short cases you are likely to get? So among the congenital heart disease, you are likely to get one fellow who is blue sitting there. So if the fellow is blue, what are the possibilities? Either it is going to be tetralogy of fallow, most likely it will be tetralogy of fallow. If it is not tetralogy of fallow, some of the tetralogy physiology will be there, like tricuspid VSDPS or single ventricle PS, and those kind of a thing may be there. Or it can be some variant form of tetralogy like pulmonary atresia, TAF absent pulmonary valve, all those things can be there. And or it can be Eisenmenger syndrome, or it can be Epstein's anomaly. Then in asymptomatic annular heart disease, you can have Rutenbacher syndrome can be kept as a short case. You can have RSOB, VSDAR, and coarctation. Then you have a list of miscellaneous conditions that can be kept. Aorta arteritis is generally kept. Then dilated cardiomyopathies, all your cardiomyopathies, RCMP, HCM, and ischemic heart disease. Nowadays, people are keeping an ischemic heart disease, which I think becomes a kind of a viva only mostly, not mostly case-oriented discussion, but a lot of things can be discussed to test your application knowledge of CAD and heart failure. So the most important facts that remain in a long case are the questions are fairly predictable. They remain the same for ages. Right? For ages, they remain the same. And actually, you can direct the question. The way you are answering, you can get the examiner to the area of your strength. You can easily manipulate your examiners, but don't try to be over smart and try to get into trouble. The answers are pretty well known. Answers are very well known. Like it's like 1 + 1 is equal to 2. The questions are known, the answers are known. Why do we falter then? Number one is lack of exposure. we lack practice. And more importantly, there is a fear of failure. You say whatever you know, also you stop remembering them or answering properly. So how do you improve that? How do you improve that? The only way you can improve your clinical skills and examination and this knowledge of the repeated questions that are asked is catch hold of your juniors and teach them all this. Like by the time you come to the third year of DM, you should be good enough to teach your undergrads, teach your postgrads, and teach your junior colleagues about clinical science as well as the common questions that are asked. So don't expect in your class like why S1 is loud in MS. These kind of questions are never going to be asked by a are going to be taught by a professor to you at the DM level. Why do you find S3 in MR? These kind of questions are you have to know. And why do you find a wide and fixed splitting in ASD? So these are some of the questions that you should be teaching your undergraduates, postgraduates, and your junior colleagues. The moment you come to that level, automatically exams will be it's like you don't have to prepare for the exam. You will go through the exam without realizing it. So once you reach that level, when you are able to teach your undergrads and postgrads, the most of the answers will be at your spinal level. Even when you're tense, when you are at your say 60%, 70% of your best, still you will be able to answer and breeze through an exam. So that is repeated practice. Second important request to all of you is do group discussion. So if you have 3 or 4 students who are preparing for exams in a given place, all of them should present to each other a case or some other common clinical problem that are existent. Whenever you find a good case, then immediately see all of you see and discuss among yourselves. Try to come to a conclusion about what findings you have. Try to get your another examiner or somebody senior to confirm the findings and try to make a clinical diagnosis before looking at the echo report. So if you streamlinely do this for 50 cases in your 3 years of DM, your exam will be a breeze. You don't have to bother about your exam. But it's about having the dedication to do this clinically and having a discipline to do it every week. So I'm just asking you to do 1 year if you prepare, say 1.5 years you prepare, start preparing. The later of your DNB or DM, just give 1 week, one case you see in detail and discuss with your colleagues. So why do we falter? The problems in the exam that happens are number one, the most important commodity in the exam, which is commonly very rarely found is common sense. Commonly, the students behave as if there is no sense. We just need common sense. Most of the time, the exam questions are just directed towards your approach, simplified approach, and how do you approach the problem? How do you solve the problem? It just needs a common sense. And my only tip is for exam is don't trick yourself. Don't overthink. Don't be oversmart. Just keep it as simple as possible. That is my third tip. So the Chris principle, which is very famously told by Dhoni, keep it simple, stupid. If you don't keep it simple, you will end up being a stupid. This is holds true across life and across your interventions also, and similarly across your clinical examination. So don't trick yourself. Keep it as simple as possible. So what are we assessing? What we have to assess in a long case? So, for example, I am giving you an example of a rheumatic heart disease case, multivalvular case. A complete diagnosis will include rheumatic heart disease, severe MS, moderate MR, and severe AR in heart failure, congestive heart failure, NOH class 3 in normal sinus rhythm with no evidence of rheumatic fever and no evidence of infective endocarditis. What are the things that are missing in this diagnosis? Can you put it in the chat box? Dr. Mithilesh, are we getting any answers in the chat box?
Not at the moment, sir.
Any answers?
Yes, sir. PAH and PVH.
Okay.
LV
Then,
function, one more answer from Dr. Kaushik, LV function.
so these are the other things that you have to know. One is severity of PVH and pH, if possible, LV function assessment, and then precipitating factors, whatever be the precipitating factors. So this is what we are going to assess. So I think I tell you that we need to assess nine things in a clinical examination at the end of the clinical examination in a long case, especially a rheumatic heart disease case. So the nine things include severity and combination of valve lesions, especially we are talking about mostly rheumatic heart disease. So severity and combination of valve heart disease, that it means severe MS, moderate AR, whatever it be the severity. So NVHA functional class and heart failure, presence of congestive heart failure. So the rhythm, the PVH and PH, ventricular function, future of carditis, infected endocarditis, and precipitating factors. So generally, we have to assess the order. Maybe I think maybe change. Like for example, you start with the severity and combination, PVH, PH, then you put the heart failure, then NHA functional class, then you go to rhythm, and the three features that you have to put in: rheumatic fever, history, any additional feature, rheumatic fever, infected endocarditis, and precipitating factors. So these three things you can keep, and these are the 9 points that you have to assess at the end of the examination. Very simple, like. So what are the tools we have to make this assessment? The most important tool that we often forget to use is our brain. So I think we should use it as much as possible with all the brilliant sparks working on the day of examination. For that, you have to be relaxed. You don't have to fear for failure, and you just have to face the examination as you have done before. It's not the end of life. It's not your the most important exam in your life, which I think so many exams are going to happen over a lifetime. Like, so it's one of the very minuscule part of your life. So the moment you think like this, your brain is simple, it works. You have common sense, you don't trick yourself, and you always keep it simple. You always focus on the areas that you know, and you are able to take your examiner to the areas that you know. So, what are the tools coming to the specifics? Again, the tools we have are can be divided into 9 only. So, in cardiology, it cannot be simpler than that. It's so simple. The clinical examination is so simple. I don't know people why falter like. So, there are three things before that. I think this is something that I want to re-emphasize. Before we go to all the examination, all of us should be aware of the basic physiology. Every one of you should be able to draw these pictures. Start from the ECG. It just needs 1 hour of less than an hour of practice. Start from the ECG. Know where the heart sounds occur in corresponds to ECG, and you should be able to draw the JVP, a ventricular trace, and an arterial trace. Same thing is going to happen at a different pressure level in the right side and the left side. So just remember to draw this like, and you should be able to know the intervals and all those things. So it's very simple. It's very easy. You should all practice this repeatedly. Coming back to the 9 point rule, I told you there's a 9 points that we have to completely assess in a rheumatic heart disease case or a valvular heart disease case. We have complete 9 important tools to assess. What are the tools that we have in general examination? We have 3 important tools. One is the pulse, one is the blood pressure, and the other one is the JVP. These are the 3 important tools that we have in general examination. So, how is the pulse like? So, AS is typically pulsus parvus et tardus. That means AS is going to have a pulse which is slow rising and low volume pulse. AR is typically a collapsing pulse or a hyperdynamic or a collapsing pulse, what is known as water hammer pulse. So in AS, when you do not get pulsus parvus et tardus, there are so many causes. Like for example, elderly patients when the AS is not very severe, and all those things, and anemia and other things like in HOCM and various other causes, the pulse may not be pulsus parvus et tardus. It's not valvular AS. Then in AR, what are the reasons you don't find uh, um, hyperdynamic or a water hammer type pulse? When you don't find, there are three causes. When it is associated with severe AS, when the rapid rise is prevented, or when there is ventricular dysfunction, or when the AR is acute. What are the changes in MS in pulse? MS can have a low volume pulse if there is severe heart failure and low output in end stage with severe pulmonary hypertension, or more commonly, patient may have AF. AF can have, because of AF, patient can have a variable volume with a irregular pulse. Same thing holds true for MR, but MR can have a very brisk pulse without the diastolic runoff. It can have a very brisk pulse, typical of MR. What happens to the blood pressure? So blood pressure can give you a very good clue. You already know about the Hill sign, But apart from Hill sign, what is the typical blood pressure in AS? AS, the typical blood pressure is going to be, say, 90/70. The systolic is going to be low. The diastolic is fairly maintained. The narrow pulse pressure will be there. So a small volume pulse will be there with a lower systolic blood pressure will be there. What happens to AR? A typical blood pressure of AR will be, say, 160/40 to 0. So oftentimes we never write like 40 to 0, the diastolic blood pressure. When there is a big difference between muffling and disappearance and the sounds don't disappear till 0, then we are likely to write like this. So again, when you don't have such a big pulse, it's again same reasons, like when you have severe AS, when you have LV dysfunction, and when you have acute AR. What is another important concept is, suppose if somebody with AR has a blood pressure of, say, 100/20 to 0, what is your inference? What do you call this? A patient with severe AR, chronic severe AR, has a blood pressure of, say, 100/20 to 0. What is this called as? Any answers in the chat box? Anybody's looking at chat box? Anybody, any answers in the chat box?
I'm looking at, yet waiting for any answer.
So patient has severe chronic AR, and now you have the blood pressure, which is, say, 100 to 20/0, 20 to 0. What do you call this? It's simple. So this is known as systolic decapitation that indicates generally
Decapitation.
associated severe AS. So simple blood pressure can give you so much information, like, so you just need to focus on that. So what are the things that you need to focus on? The JVP. JVP gives you excellent information about all your right-sided lesion, except with the exception of maybe Epstein. Epstein, this is often normal. MS and MR may develop features of pulmonary hypertension and right heart failure, mostly MS. And ASD, generally, everything that is on the left side is directly seen on the right side. And obviously, CCP and RCM, all your pericardial diseases and right-sided cardiomyopathies are very well represented in JVP. You should be aware of all the changes, all the JVP description. So what are the things that you should remember, or what are the things you should remember about all these lesions? What happens to the level of JVP? What happens to each of the waveforms? And what happens to the respiratory variation and the hepatojugular reflex? These are the 4 components of JVP that you should be understanding. So just looking at, in a multivalvular heart disease case, just looking carefully at JVP, BP, and pulse gives you so much information. Oftentimes, these factors will be very, very deterministic of the severity of lesion, like, for example. So a lot of information can be obtained. For example, if you find a patient with MS-MR, the moment you find elevated JVP, that means MS or MR is absolutely severe. The patient has severe pulmonary hypertension. Without that, this cannot happen. Or patient has organic tricuspid valve disease. So these are beautiful information that you can generate from your JVP and pulse and BP. Moving further, what are the things that we need to? We know how good are we in so how good are we in auscultation? So our endeavor is always pick up everything before you put your stethoscope, and then confirm everything with your stethoscope. For that, again, out of the 9 rule, we had 3 in general examination, 3 before put your stethoscope. So those important 3 things are apical impulse, parasternal heave, and presence of palpable sounds and thrills. So these are the 3 important things that you find. So left parasternal heave is very simple. You just have to grade it, grade 1, 2, 3. So grade 3 always indicates severe RV, RV, RV. Most of the time it is RV, that is what is represented by left parasternal heave. You can just confirm the RV with your epigastric pulsation also, and you can confirm the predominant RV with your apical impulse also. Very rarely, this left parasternal heave can be because of a very dilated LA. With such chronic patients are generally rarely found. And how do you differentiate between LA and an RV left parasternal heave? Mostly it's RV only. 90-95% of the time in today's practice, it's RV only. Very rarely it can be because of LA. LA will be atrial contraction. That means it's a pre-systolic pulsation, whereas RV will be a systolic pulsation. So what are the situations in which you have very high RV pressures, but there is no left parasternal heave? Can anybody write on the chat box? What are the situations in which the RV pressures are very high, almost systemic, but there is no left parasternal heave?
Your response systolic pulsation in right ventricle.
So RV pressure is systemic, but no parasternal heave. Very simple, like they keep it simple, like. So that happens mostly in tetralogy of Fallot as well as VSD with Eisenmenger syndrome. So both of them, you have a large VSD, which is actually both the pressures are equal. The RV is actually not under stress, and it is able to. It's not under stress because it's able to happily pump into the aorta even if the stop and RVOT obstruction is there. The moment the ventricular septal defect is not there, RV goes into trouble. Then the heave starts to appear. So these are situations you should remember about left parasternal heave. About apical impulse, what is the location of apical impulse in AS? AS has concentric LVH. So concentric LVH, what happens is the apex is generally located at the same place. It is not dilated, it is not shifted out. The concentric LVH happens at the expense of the cavity. That means it's an ingrowth. The concentric LVH is going in, not outside. So the apex is generally located in place, except when there is LV systolic dysfunction sets in an isolated AS. Then you start getting a dilated apex. In AR and MR, typically you find a dilated apex which is located down and out. In MS, it is mostly located outwards. It's RV. So from location itself, you can make out which is the dominant lesion like. So AS is the same place. MR and AR is down and out, whereas MS is going to be out. Here, I think you should be able to make out the difference between RV versus LV. How do you differentiate RV versus LV? First and foremost, it's like a typical undergraduate point-wise point like RV is outwards, LV is down and out. Number one, point number one. Point number two, most often than not, RV is a diffuse apical impulse, whereas LV will be a very localized apical impulse, like a ping pong ball, like comes between the two ribs. It is generally another important thing at DM level is you should be knowing about the overlying skin's retraction. RV produces a lateral retraction, whereas LV produces a medial retraction. Then the fourth important point is the left parasternal heave will be continuous with an RV apical impulse. Whereas if it's LV and left parasternal heave is prominent, there is going to be a gap. It's not continuous. So these are the 4 points that you have to differentiate between RV and an LV apical impulse. Let us revise again. One is the location, down and out versus out. Then you have the retraction. Then you have the localized or diffuse. Then you have whether it is continuous with your parasternal heave or not. This way you can differentiate whether it is LV or RV. Don't confuse anything. Just character has to be just one out of the three in all your valve heart disease cases. What is tapping apical impulse? Tapping apical impulse is your palpable loud S1 that you get in MS. So it's like a palpable sound. Tuck, tuck, tuck. That sound is actually palpable. That is what is a tapping apical impulse. What is a hyperdynamic apical impulse? Suppose if you have to draw the curve of apical impulse, it is very forceful, but it is not sustained. Forceful and ill-sustained is hyperdynamic. Whereas if you have to draw like this, if it is forceful and it's sustained, then you call it heaving apical impulse. So tapping apical impulse MS, hyperdynamic MR and AR, and heaving apical impulse is AS. Pressure overload versus volume overload. Then in the apex, you can feel the sounds and the thrill. Generally, when it comes to thrills and sound, all the thrills that are generally palpable at the base of the heart are going to be systolic. All the thrills that are palpable at the apex of the heart are going to be diastolic. With the exception being rarely you can get a systolic thrill of MR. So that is the only exception. So generally, if you keep this rule, most of the time, 95% of the time, you will be right. Then palpable sounds, you generally palpate the P2, which is quite loud and palpable. But remember one thing, most of the diastolic sounds, that is S3 and S4, the low pitch diastolic sounds are better palpable than auscultable. So always put your patient in the left lateral position and palpate for your S3 and S4. So these are the three things that you are looking at. It's very simple. Keep it simple, like left partial heave, what do you find? RV is plus or not there. Then you find the apical impulse. Where is it located? Is there a cardiomegaly? Is it RV or LV? Or is it what is the character of the apical impulse? Which is characteristic of AR, MR, AS, MS? Which is the predominant lesion? And then look for additional sounds and thrills. Like it's so simple. Like with this, you should be able to come to a complete conclusion in a given case before you start putting your stethoscope. So that should be your approach. Just put three things in your general examination and three things in your physical examination before you put your stethoscope. So this should be able to enable us to get into auscultation. So what are the things that we are going to hear here is heart sounds, that is S1, S2, S3, S4, added sounds like opening snap, pericardial knock and other things, even S3, S4 can be here. And then murmurs. It should be added, not added murmur, but added sounds. And then murmurs. This is what we find. So before we revise again, what do you find in various lesions? Let us now go to individual valve lesions and how do you assess severity? What are the indicators in all these nine kata that I have told you? Like you just divide it into 9 parts and how is it going to look like? So severe MS, we start with severe MS. You have a prolonged diastolic murmur is generally indicative of severe MS. So here, remember also, most of the time when you want to remember the character of the murmur or the duration of the murmur, how the shape of the murmur is, you are all echo generation. Immediately think of the hundreds of echo, thousands of echo that you have done for severe MS, how the graph is going to look like, the Doppler graph. Same thing you are auscultating. So if it's a mild MS, it's going to be like this, the graph. Whereas if it's going to be severe MS, it's going to be like this. So you have to look at that. Like it's going to be a prolonged diastolic murmur. There can be a thrill associated with it. A to YS gap is inversely proportional. There is going to be pulmonary hypertension, cardiomegaly, and congestive heart failure can be there in severe MS. Presence of AF, intensity of the murmur, and pre-systolic accentuation per se alone do not correlate with severity of mitral stenosis. So, but in a multivalvular heart disease, the prolonged diastolic murmur, the presence of a diastolic thrill, and A2OS gap stand out. But there are various other facets that also affect the A2OS gap also. So this is a very important diagram where you can remember all your sound that happen, ejection clicks, the opening snap, the tumor plop, and the S3 and S4, and the pericardial knock in between. So this is the order in which it happens. So remember that, like. So how do you assess severity of MR? Again, cardiomegaly will be there. S3 will be there. Can be a diastolic murmur because large amount of flow goes into the LA and excess amount of flow has to come down into LV. So remember that you can have a diastolic murmur across mitral valve in two situations: when the mitral valve is stenosed or when there is excess flow going through a normal valve. So here excess flow is going through a normal valve that can also produce diastolic murmur. The moment a diastolic murmur happens in MR, it is going to be severe. There is going to be wide split of S2. A thrill may or may not indicate severity. LV systolic function and pulmonary hypertension and congestive heart failure are the key things that are important. In a multivalvular heart disease, everything else can be because of something else. For example, cardiomegaly can be because of AR, S3 can be because of something else. The thrill is not very helpful. LV dysfunction, pulmonary hypertension, congestive heart failure can be because of something else. The only thing that stands out will be a wide split S2. In severe AR, your pulse helps, the Hill sign helps, duration of diastolic murmur helps. Austin Flint murmur indicates severe AR. Extraordinary thrills to have in AR, cardiomegaly, S3, LV dysfunction, and pulmonary hypertension, congestive heart failure are common to all, but they happen very, very late in late stages in AR and AS. So the ones that stand out in a multivalvular lesion are the Hill sign, duration of diastolic murmur, Austin Flint murmur. These are the ones that stand out. Hill sign, we know that above 60 is severe, 40 to 60 is moderate, mild is 20 to 40, and normal is 20. But there are a lot of maybe a sign, maybe a true sign, or maybe an artifact. So there's a lot of discussion happening there. But still, it's a useful clinical sign. It may be falsely low in LV dysfunction, acute AR, and associated AS. AR murmur may be rarely auscultated towards the right side of the sternum. The moment you are able to auscultate towards the right side of sternum, it can be aortic aneurysm, cystic medial necrosis, syphilis, or idiopathic, or it can be sinus of valsalva aneurysm, it can be aortic dissection, or selective perforation or eversion of the right coronary cusp can be there. What are the signs that are found in severe AS? They are pulsus parvus et tardus. The peaking of the systolic murmur is a very, very important feature of severe AS. You have paradoxical split S2, LVS4, epicocarotid delay, which is often neglected. Atrial cardiomegaly, LV systolic dysfunction may happen in the end stage. Pulmonary hypertension, congestive heart failure are very rare. The ones that stand out are a lot of things actually stand out in severe AS. So things that stand are aortic valve disease, the pulse and the Hill sign, the murmur characteristic except for MR, the diastolic thrill, and the paradoxical split S2 of AS, and the wide split S2 of MR stands out in all multivalent heart disease. And A2OS gap mostly stands out. Some of the rules of the combined lesion are like severe lesions tend to dominate. Then you have a proximal lesions tend to dominate, like means TS protects or masks the mitral valve or aortic valve lesions. Then you have multivalent disease, 1+1 may not be 2 because there is a good amount of ability to compensate. So let us do the reverse. So we have talked about 4 lesions. We will not talk about the right side lesions for simplicity. So we have AS, AR, MS, MR. So how do you assess the severity of each of them? So first we talk about the murmur. So in MR, the LA pressure is so low and LV pressure is so high throughout systole, you get a pansystolic murmur. You get a pansystolic murmur whether it is mild, moderate, or severe. MR is the only condition where the murmur characteristic doesn't help you except for a presence of thrill, which also is controversial. Like whether the presence of thrill indicates severe MR also, it's a controversial thing, but that could be only characteristic of murmur that can help you in assessment of severity. In AS, what is the most important characteristic of the murmur that helps you in assessing severity is the duration of the murmur. More important than duration is the late peaking murmur. So oftentimes I find in the exam, because of this clarity of understanding is not there, they describe everything, but they don't describe the peaking of the murmur in a ejection systolic murmur, which is wrong. Same thing, the duration of the murmur is the most important critical thing in both diastolic murmurs, MS murmur as well as AR murmur, because they indicate severity. Period. Full stop. What about additional murmurs? What are we seeing in additional murmurs? Additional murmurs, you find a MDM. MDM in a rheumatic heart disease is found in so many situations except for MS. Apart from MS, if MR, there is a flow murmur, indicates severity. If you find Austin Flint murmur, it indicates severity. So both MDM can happen. But even a flow murmur across aorta may or may not indicate severity. So this is about additional murmurs. What about additional sound? Opening snap, A2YS gap for MS. You have LVS3 for both AR and MR. And you have generally S4 for AS, but later on when LV starts, systolic dysfunction sets in, you can have S3. So these are the various additional sounds that can be there. What about S2? Generally, AR doesn't help too much with S2, but there are some various changes written about S2 in AR, but they're not very helpful. Except for AR, other things it's very useful. So in MS, you find loud P2, a loud P2 because of pulmonary hypertension, whereas in MR, you find a wide split second sound, and in AS, you find a paradoxical split second sound. The moment you have such a clear understanding, so how much things you have to understand, you remember. It's so simple. It's so simple. But the moment you have it in crystal clear in your thoughts, you just don't get it wrong. So let me reiterate again. You just have to look at these 9 signs to come to a conclusion about the 9 things we discussed about. So at the end of the exam, we want you to bring out 9 things in your final long case. That includes the lesion severity, or the various lesions that are there and the severity. Then you want to assess the PVH and PAH. Then you want to assess whether there is congestive heart failure is there or not. The NOHA functional class that has to be there, whether it is sinus rhythm and if possible LV function. Then the 3 things that acute rheumatic fever, features of infected endocarditis, and precipitating factors. If you are able to bring out these 9 things, more often than not, you will have a complete diagnosis. But it is not, we are not at DM level, you don't expect to be parroting everything. For example, in a tetralogy case, I don't want you to report PVH and PH because they are not there. It's severe PS, so there is no PVH, there is no PH. You don't have to write PVH, PH in those cases. Many of the clinical situations, you may not be able to find out the LV function, so you can just skip that. So because of want of time, some of this, but again, same thing. If there is severe MR, if there is MS. So severe MS means you have to, which is severe. So again, you have to look at the type of apex, what are the characters of the diastolic murmur, what are the added sound that are there, then whether the pH is there or not, what is S1 and S2. So these things I will skip some of the things. So what is about TS? So TS is something we'll cover some of these aspects in the multivalent heart disease case. So TS is something that escapes detection. So more often than not, they present with fatigue and heart failure, less PND and orthopnea. JVP is generally the key. Giant A waves and slow wide descent is there. You have pulsatile liver. Murmur of TS, generally the location is tricuspid area. There is a pre-systolic or mid-diastolic, and inspiratory augmentation will be there. The moment you find a TR in a rheumatic heart disease there, it has to be either organic TR or a low high pressure TR. How do you differentiate them? You have a murmur which is pan-systolic murmur in a high pressure TR, whereas a low pressure TR, it's a early systolic murmur with variable duration. Pitch is generally high and low pressure is low. The shape is pan-systolic. It's a decrescendo murmur here. Generally, you find other signs like the JVP will have large CV waves and P2 will be loud, whereas P2 will be normal in low pressure TR. You don't find parasternal heave, and all those things will be there. So, in general, you are supposed to classify PVH. PH is generally mild, moderate, and severe. So, this is how it's classified. So, 20 to 30, 30 to 50, like 50 and above is severe. Systolic pressure is 50 to 70. And then, how do you assess in children? Is again percentage of systemic. So PVH classification, everybody should know, like below 12 is normal, 12 and below is normal. So then 20 and up, 25 and above is severe. So how do you assess presence of severe pH? If the P2 is palpable, generally it indicates severe. If P2 is louder than A2 compared to A2, it's loud, it's very clear. If P2 is heard at the apex, it is loud, with the exception being ASD. If it is palpable, it is again loud. That indicates severe pH. Left parasternal heave, presence of RBS3, S4, a constant ejection click, murmur of TR, ejection systolic murmur in the pulmonary area, and murmur of PR. These are the things that will tell you that it's signs of pH that are there. The moment you find a murmur of PR, it can be low pressure or high pressure, similar to TR differentiation, whether it is high pitched or low pitch, what is the duration, whether it is a brief decrescendo of low pressure or other features like palpable is there or not. This is something that commonly I find the students to falter. How do you assess PVH in a given case? So PVH is assessed by presence of symptom class. There is pulmonary edema, like class 4 patients generally have severe PH. If there is gross cardiomegaly in the presence of an AS or an MS, indicates definitely the patient has to have severe PH. So from the PA pressure estimation, the moment you find severe PH in an P2 is palpable, that means severe PH is there in an MS case, the PVH has to be severe. And then from your RA pressure estimation, the PVH can be really estimated. Like we will discuss that from hemodynamics when we discuss like commonly PND is considered not as class 4, whereas orthopnea is considered class 4. So a class 2 patient can have PND. So if modifies the clinical finding, S1 becomes variable. The diastolic function assessment becomes tricky, MS and AR assessment, and how to measure breast pressure. Are automated instruments good enough? These are questions that you should find answers. How do you find LV function in a given rheumatic heart disease? It's extremely difficult. There are so much is being written about the accuracy of echo for assessment of LV function in rheumatic heart disease, leave alone clinical examination. So there are some rules that work out like. So LV S3 does not mean LV systolic dysfunction, especially in the presence of MR. MR S3 doesn't mean LV systolic dysfunction, whereas AR it means systolic dysfunction. You read about it, why? Then Bispherians pulse, the moment you find it, it indicates normal LV function. The other important thing is the volume overload, you find a hyperdynamic apical impulse, which is shifted down and out. The movement in that situation, down and out apex, which is not looking like hyperdynamic, but it's becoming sustained, it is indicative of LV systolic dysfunction. The opposite is true, a dilated heart and a diffuse apex in a pressure overload. For example, AS, you find a dilated heart in an isolated AS, and at the same time, you find a diffuse apex that indicates LV systolic dysfunction. So these are the various clues of LV systolic dysfunction that you can get. So sometimes in a given case, you can find out of proportion heart failure in a valve case. That would include organic TR, Luther-Baxter syndrome, RSOB, and predominant RV, CCP, and others. These are the common precipitating factors that you can find. So in the 9 things, I've helped to find out how do you make the assessment like. So the other important thing is how do you diagnose rheumatic fever recurrence without established RST and with established RST. With established RST, most of the routine patients that are kept in the exam, you need 2 minor plus evidence of preceding group A streptococcal infection. How do you assess diagnosis of rheumatic carditis? Various things you can find: apical systolic murmur, cardiac murmur, or air murmur. Myocarditis, you find disproportionate tachycardia, cardiomegaly, gallop, and heart failure. You may find rub and effusion. Subcutaneous nodule and rub and new murmur are clinical signs that indicate the given patient has a new onset of carditis. So generally JVP tweets about the right side, Pulse and BP WhatsApps about the left side. ASD and RSOV actually gives additional likes for the examiners, but lot of dislikes for the examinees. So PVHR left parietal heave can be from the symptom class, from pulmonary edema, as I told you, cardiomegaly, from RA pressure estimation and the PA pressure estimation. Whereas the write the pressures in a multivalent case, JVP is generally equal to the RA pressure. You can estimate the PVH, you can estimate the pH from the blood pressure, and then you can estimate from the pH from the other gradients. You can actually write the whole thing. You should start practicing this. So my take-home message is diagnosis and severity of valve lesions by clinical examination is very interesting and an educative exercise, but do not tend to overdiagnose it. Keep it as simple as possible. Tend to specify mild and significant, surely, and it has to be practiced to keep this art of bedside teaching live. So as I told you, keep on teaching your undergraduate and postgraduate with your examination in mind. Echocardiography, Doppler remain the gold standard. We all know that. But still, clinical examination should not be delegated to the role of just a screening tool. So thank you for your patient listening.
Thank you, Dr. Ramakrishnan, for providing a complete overview of how to approach a long case in the clinical examination. So we have a few questions in the chat box. Uh, so if you can take up a few of them. So sir, should I start with the question answer?
So the one of the question is that how important to highlight negative findings in a long case? Does it make any difference in differential diagnosis related questions? Yeah, absolutely. I think negative finding or positive finding, all these 9 things must be there. Like you cannot miss a left parietal heave if it is there or not there. So whatever, if it is there or not there, these 9 things you have to definitely tell in an examination. Like for example, JVP, pulse, BP, all those things must be told. Like, and that helps you. Like for example, many of you get a lot of time after finishing your long case. Just remember to put these 9 boxes together with your final diagnosis that you come up with, whether it is fulfilling all the things that are there. Common mistake that you find as a almost now a regular examiner to many exam students. I've seen so many students is commonly the common mistake. Like you present a case of ASAR, we repeatedly ask you which is the most dominant lesion. You say it's AS, but where is the apical impulse? Apical impulse is in 7th space, dilated and down and out. So these are the common mistake that we find. So this is just put a box like this, put 9 things, what are the major findings in the 9 boxes, and try to fix all your diagnosis is fitting or not. That's a very simple exercise that can actually solve a lot of your problems. The other question is what is systolic decapitation? As I told you, like in AR, you expect the blood pressure to be the systolic to be very high. Like for example, 160 mm Hg. The diastolic will be muffling will start at 40, but disappearance will not happen until 0. So the pressure in AR is written as 160 by 40 dash 0. But in a associated AS is there, the pressure will become 100 by 40 to 0. There is reduction in systolic pressure from 160 to 100, for example. So this is known as systolic decapitation. In any given AR case, if systolic decapitation is there, generally it indicates severe AS, associated severe AS. Maybe it also could indicate associated LV systolic dysfunction rarely. What about apex seat in combined severe bivalvular lesion? So whatever be the dominant lesion, that will take care. Like suppose if an MS and AR, if it's the MS is dominant, generally it is outward shift and the RV type apex. If AR is dominant, it is going to be um, outward, down and out LV type of apex. Same thing goes true in AS and AR. If AS is dominant, AR is mild or moderate. Generally, there is no cardiomegaly. The apex is the same place, and there's a heaving type of apical impulse. If it is a AR dominant, it is going to be dilated down and out. So it all depends which is the more dominant lesion. So how to assess medial and lateral retraction? Unfortunately, it cannot be, it has to be seen in the bedside. I think you can ask your seniors to show that like. It has to be shown. It has to be live, shown in a live case. Any other questions?
Just a minute, sir. Yes, sir. Final question.
I think they are asking unrelated questions, but how can we differentiate between unstable angina and NSTEMI in patients where angiographic finding is not available? That report's awaited. I think generally, very rarely you can have a typical ECG changes of a NSTEMI, symmetric T wave inversions or a very strong new onset ST depression, which are persistent. That can generally indicate it could be NSTEMI. Persistent ST changes, not amounting elevation, you can make a tentative diagnosis of NSTEMI, but NSTEMI versus unstable angina, the critical thing is not angiography, but the critical differentiating feature is the enzymes. So if both the lesions are severe, then how to assess apex? So you assess apex, how is it? So then you interpret it like, not the other way around. It has to be, that's what I'm told you. Like you just stick to these 9 findings, don't get any of them wrong. Try to get all of them correct. And then you interpret it like whatever, for example, if there is MS and AR, it can be either way. If both of them are severe, it can be either way. Most likely it is going to be down and out. So it all depends like. So there you don't look at this like. So the apex beat character in dextrocardia will not change. It is going to be hyperdynamic. It's going to be heaving. It will be again outwards or downward because the orientation of LV versus RV is going to remain the same. Just it's towards the right.
Yeah. Thank you very much, sir. We do not have any more questions. So, with your permission, can we end the meeting?
Yeah, fine.
Yeah. Yeah.
And
So,
you
sir,
get the feedback from the students so that we'll plan the classes accordingly. So we will have the class again on the last Thursday of every month. So I think we'll plan it that way. Like
sure, sir. With this, it's my great pleasure to give a vote of thanks. So, first and foremost, I express our deepest gratitude to our post-director, Dr. Ramakrishnan, for uh, giving us this new concept and leading this academic initiative. Your vision and guidance have truly shaped this program into an enriching learning experience for all the participants. I also thanks our participants for their enthusiastic involvement. Your curiosity and active participation have made the session highly interactive and meaningful. And with this, we conclude today's session. We look forward to your continued support and active participation in the upcoming session. Till then, thank you. Have a wonderful day ahead. Thank you and
thank
good
you,
night to everyone.
thank you, thank you.